Good afternoon. On behalf of the Patient Safety Authority, I'd like to welcome you to our webinar, the PSA Introduction to a Candor Collaboration for Pennsylvania Healthcare Facilities. My name is Michelle Bell, and I'll be your moderator for this program. Now I'd like to introduce our speaker today. Dr. Seth Cravat is the Senior Medical Director and Assistant Vice President at MedStar's National Center for Human Factors in Healthcare. He's an Assistant Professor of Clinical Medicine at Georgetown University and an attending physician of palliative medicine at MedStar Georgetown University Hospital. Dr. Cravat is board certified in both internal medicine and hospice and palliative medicine. Seth, I'll turn the program over to you.
Thanks, Michelle, and thanks everybody for having me today. Looking forward to the presentation on Candor. We're going to start with a safety moment just to get us in the mindset of why we're having this conversation today. What you see here is a video that's about 6 minutes of a patient who is very supportive of the Candor process. And while you're watching the video, of course, it'd be great if we could all be in person, but we're not. So just be mindful that sometimes the video and the film itself and the audio don't match up. But hopefully you can be patient as we go through this.
In the summer of 2013, I began to experience a shooting pain in my right arm. I was having a difficult time holding a golf glove. I was losing the strength in my right hand. I went and had an appointment with my internist who recommended therapy, and it really didn't have the effect that I wanted. Dr. Torlani recommended surgery. Things didn't go as planned. The 2.5-hour surgery took about 5 hours.
I've been practicing medicine, practicing orthopedic spine surgery for 13 years. So when I was doing my training, we were taught, maybe not too different than the airline industry, if there is something that's not typical happening in the operating room, first pause, and then second, call a trusted colleague and tell them about what you're experiencing and tell them what your plan is to get out of whatever the challenge is that you're in. Then mention it and talk to the family about it real time so that everybody is in the loop.
And I was thinking, oh, he's finished. He just wants to tell me that they're done and he's moving on and, you know, he'll be out shortly. And instead it turned out that he said things weren't going very well. Dr. Tortolani explained to me what was happening. He gave me 2 options, that he could either abort the surgery or he could continue with his new plan. And he wanted my permission to continue, and I said yes. I know it was very difficult for him, and I was very thankful that he did come out and talk to me, but I could tell for him it was very hard because he had known Jack for a while.
When I woke up in the recovery room that evening, I learned that I was paralyzed from the neck down. I had always been a fighter, and I told him, I said, let's get the show on the road. Let's figure out what we're going to do and get it started.
The difficulty that I've had with this gets to just trying to internalize something that was really tough, but their family has made it so much easier for me. And how dedicated they have been to his recovery has made it so much easier. And the fact that they did not push me away as their doctor has made it incredibly better in terms of maintaining a relationship.
You went way beyond apologizing, way beyond saying that he was sorry.
I mentioned it to our administration to let them know about this incident, just to make sure that we were doing everything we possibly could to support them. And they just brought it to a whole nother level of support for their family.
I don't remember exactly when I got the call from the risk manager who was on site at the local hospital. But when he called me, the question was, how do we deal with this? What should we do? When you work in an organization where the directive is to do the right thing, the answers are really easy. Tell them basically anything they need is what we're here to give them. We have to support them.
I was shocked personally that the hospital did say something happened on our watch. We want to be responsible for it, and we want to help you in any way we can.
Don't worry about it. We'll take care of it. And they did.
The first week Jack was in the hospital, we were supposed to be transferred to Good Sam Rehab, and we found out that our insurance was not going to pay for acute rehab. And immediately the discharge planner told us that MedStar had decided that they were going to pick up the tab for that, not to worry about it, that we were going to transfer him and get him the help he needed.
I went in the hospital as a patient, and then I became a victim. And that's not right. As a victim, the early intervention allows the victim/patient to get on with their life a little quicker.
If we're there in the very beginning, we can make sure they have home health aid. They have somebody in the house to take care of them. They have attendants if they need to, somebody to take care of their needs. That all can be done in the very beginning. In the old traditional way, I'm just looking at picking up the pieces after everything has been broken. In the new way, we're looking at taking those pieces and making sure they're melded together to get the patient the best outcome possible.
It's really made it much easier for me to just keep doing what I do and what I love to do.
MedStar did it all. They did emotional support, they did physical support, and they did monetary support. I think all of those things together are what's going to make it a success.
It was one less thing I had to worry about. It allowed me to concentrate on getting better. That just made life a lot easier for me.
Just so all of you know, I know Jack pretty well. We've done talks together. He was in the Baltimore Police Department, actually in the SWAT team for maybe 30 or 40 years. He's very active. He did something called spelunking, which I learned what it is from him. He was a sailor, and this was really traumatic for him and his family, yet they are true advocates of what we did at MedStar. And he speaks very positively about the experience for it being a terrible experience. And he also gave us the opportunity to learn from him as a patient. So I show here, moving on to our talk today. So this picture is of the crash of this Asiana 777 in San Francisco in the summer of 2013. And I show this picture because you see the NTSB arriving to investigate and figure out what happened. And the NTSB doesn't show up a month later, or 2 months later, or 3 months later. They show up immediately when a plane crash occurs. In healthcare, when things go wrong for our patients, we often find that there's a delay in our showing up, whether it's communicating with patients and families, taking care of our caregivers, or actually doing event reviews to find out what happened. We're waiting for people to get together. We're working around other people's schedules. But we don't often show up as quickly as we should. And what we've heard repeatedly from the patient's and family's perspective is that when something like this happens, when people have unanticipated outcomes that are severe, it feels like a plane crash to the family, and they want us there now. So for the NTSB, they have something called the GO team, and if you read here, at the core of the NTSB investigation is the GO team. The purpose of the Safety Board GO team is simple and effective. Begin the investigation of a major accident at the accident scene as quickly as possible, really important here, assembling the broad spectrum of technical expertise that is needed to solve complex transportation safety problems. So what we did at MedStar and through the Candor process is we applied this to the healthcare GO team, which is our next slide, please. A healthcare Go team is very similar, a team of trained individuals who respond to patient harm events and coach others on how to respond in a timely, empathetic, consistent, patient-centered, and effective way. There are at least 4 components of the healthcare Go team. We're going to cover probably the first 3. Resolution, I'll just mention, is how we actually close out a case. How does that actually work in the end? What are the final things that our patients and families need? But the main 3 buckets are disclosure and communication with patients and families, so how we talk to them when these things happen. Care for the caregiver, ensuring that we are actually caring for our teams who did not intend to harm anybody, similar to what we heard from Dr. Tortolani. And event review. We call it event review at MedStar, not RCA, and we'll talk a little bit about that. So I'm going to start with disclosure and communication with patients and families. So what is disclosure? So here it is defined. So disclosure refers to communication between a healthcare professional and a patient, family members, or the proxy that acknowledges the occurrence of an error, discusses what happened, and describes the link between the error and outcomes in a manner that is meaningful to the patient. And really important here, and I might mention again later, that disclosure is not a one-time event. It is truly about ongoing communication with patients and families. So why do we do this? Why is disclosure important? Really, patients have a right to know the details associated with unexpected outcomes. So if we did something wrong, or even if we didn't do something wrong, but the outcome was unexpected, these are their bodies. They should understand to the best of their ability what happened. It's their right. It opens an opportunity for compassionate, professional, and patient-centered care, which is what we all are trying to do every day, and this should not stop just because something went wrong. We don't want to close the door to this opportunity, especially in the midst of an error. And next, this increased organizational learning could translate into safer systems-based practices and possible repair of the patient-caregiver health system trust. So this learning part is really important. We'll talk about that more during the event review portion of the talk today. So it's the right thing to do. It's part of the AMA Code of Ethics, saying that truthful and open communication between physician and patient is essential for trust in the relationship and for respect for autonomy. That's the patient's autonomy to choose what they want based upon having the full amount of information about what's happened and what's going on. Withholding pertinent medical information from patients in the belief that disclosure is medically contraindicated creates a conflict between the physician's obligations to promote patient welfare and to respect patient autonomy. And this applies when you're worried, both when you're worried that something could be contraindicated, that I don't want to disclose because I'm afraid it's going to harm the patient, but also I don't want to disclose because I'm afraid it's going to harm our organization. It doesn't take away from the need that this is the right thing to do. Why do patients sue? So that's we sometimes hear people say, I don't want to disclose or communicate or share information because we're afraid that patients are going to sue. So we take a defend and deny stance. But why patients sue? One, because healthcare organizations fail to provide adequate information on how the injury happened and why. I've heard this repeatedly from multiple patient advocates on our MedStar boards who have said the reason why they ended up suing was because they couldn't get information about what happened any other way. And while we're on this, they say that we harm patients and families the first time when we harm them, and we harm them the second time when we fail to give them this information. Number two, an explanation. The organizations fail to provide an explanation of how future patients will be prevented from similar harm. Again, this is something that was taught in Candor, but it's also something that I've repeatedly heard from patient advocates, and most of them who have lost children to medical error. So their concern is often not initially about how much money will I get from the organization. They don't want this to happen to somebody else. Number three, organizations fail to provide financial or other support in the immediate aftermath of the harm event. And we'll talk a little bit about this too. It could be as simple as parking, covering parking, but it can be much more complicated than that too. But in the middle of a medical error, patients have their regular lives to deal with. Healthcare organizations fail to provide, number four, long-term compensation for actual losses. So if we did harm you and you are unable to work again, we probably owe you something. And number five, acknowledgement of responsibility for the error. So I just want to know that you are taking responsibility for this and doing everything you can to make sure it doesn't happen again. Full disclosure, which accounts for the needs of patients who have been injured and their families, addresses the primary reasons that patients sue. So remember, we're focused on, we've harmed somebody, what do they need now? It's not really about what we need, it's about what they need. So apology statutes, and this is actually a quote from a plaintiff lawyer who we worked with, they will fight these because you can read the quote, I'll read it and then I'll tell you what they said to us in summary. So I'd agree to caps on pain and suffering before I would agree to the inadmissibility of apologies. If healthcare organizations ever learn how to respond to patients who are injured, my doors will close. People come to me not because they are injured, they come to me because they are angry. And this is from a plaintiff lawyer who's won millions and millions and millions of dollars in suits. He insists that people come to him because they're angry, because healthcare organizations won't talk to them and be honest with the patients themselves. And so he says, if we learn how to do that, if we learn to actually listen to our patients and families when something goes wrong, to understand what's important to them and to provide that information, he feels that plaintiff lawyers will actually go out of business.
So what we have on this slide is a graph of the liability costs at University of Michigan Health System. And what you can see on this graph is that before the year 2001, they had not implemented their full disclosure program. But then after that year, after they implemented their disclosure program, their liability costs went down. And what this paper suggests is that because they were doing full disclosure, they didn't have the legal fees and the legal costs associated. It looks like Seth is back now. I'm going to hand it over.
So I think Zoe did a great job. I was able to hear most of it, talking about disclosure and legal expenses. A lot of times we hear from insurers that they don't want to do disclosure because they're afraid that these claims are going to go up, and that just was not the case at the University of Michigan. And I'll show you some data from MedStar later on that has also not been the case for us. Actually, quite the opposite. So early intervention resolution. So early intervention, this is really important. It's a process of bringing resources to patients and families in the immediate aftermath of a serious unanticipated outcome. So what happens is, in your organization, hopefully, people have a way to report when something called a serious unanticipated outcome occurs. So a patient, let's say, is going for an elective knee surgery, has a cardiac arrest in the middle of the surgery. We don't know why, but what we do know is that this is not what the expected outcome was. We have a lot of work to do, but immediately we have to get to the patients and families, begin that communication, and then part of that communication is, as I said earlier, is understanding what do they need right now. And different people need different things. Sometimes they may say they need absolutely nothing. Other times, perhaps somebody wants to stay near the hospital. They've visited from far away. So what we end up providing at MedStar is accommodations. We can provide travel arrangements. Someone is across the country, a child, and needs to come here. Food and parking. These are the kind of things we really don't want our patients and families worrying about, especially in the immediate aftermath of one of these events. It's the last thing that should be on their mind. They should be focused on caring for their loved ones and processing all of this. Sometimes people actually they can't work. They're a family member and they cannot work, or the person in the hospital is, the person who was harmed actually was the main breadwinner for a family. We can actually provide support until these things are figured out. And then there's everything from psychosocial support, from therapy to daycare. We've actually provided all of these different things at MedStar to our patients, including probably a whole bunch of other stuff. Overall, these costs are not enormous, especially when you think of, one, it's the right thing to do, and two, it's much, much less money than making people angry and having them come back later and asking for large sums of money because they're angry. we do this because it's the right thing. I really point that out, that it's not huge amounts of money based upon all the money we spend on risk in healthcare. So what are the benefits of early intervention? It gets these resources to the injured patient and or their patient and or the family when they most need it, which is in the immediate aftermath usually of one of these events. It can reduce costs for everyone involved, as I mentioned on the previous slide. We say avoids turning a caregiver into a defendant, meaning the nurse, the doctor, anyone else involved is less likely to get sued if we can provide some of this initial support up front. And it often narrows down the issues and the parties. So now let's get to the people who are providing the care, so care for the caregiver. Some people actually call this the second victim. We don't use that term in MedStar because there's some discomfort in the patient and family advocate community around using that term. So we focus on care for the caregiver. This is really support for caregivers after they're involved in medical errors or any serious unanticipated outcome. Say over and over that it's rare that someone in healthcare has come to work to do anything but try to make somebody better. And when people come in with the best of intentions and something goes terribly wrong, it's traumatic. Historically, we have not taken care of our caregivers, and it's really a missed opportunity to do what we do best in healthcare, which is care for people. So this is from AHRQ in 2017, also known, it's part of the Susan Scott model from University of Missouri. It really breaks down care to the caregiver into three kind of tiers of support. So the base tier is just people on your unit showing caring and empathy when something happens. So it's asking somebody how they are. It's giving them a hug. Of course, we're not doing that much in COVID anymore, but it's just being there and being supportive. The next level, and let me go back to that one for one more second, this becomes part of an organizational culture. So at MedStar, this is something that people just do now. And so locally, it's not that hard for somebody to start providing this. The next level of support is actually providing training for people to do care of the caregiver throughout your organization. And this is a kind of people are a little more comfortable stepping in and supporting somebody, debriefing with that person, understanding what to talk about, understanding what's not helpful to talk about, and just supporting them on a day-to-day basis through all of this. This is really important as it's a little more structured, and also it allows us to screen people to see if they need the next level of care. And that takes us to tier 3. Some people call it employee assistance program. It's being able to refer people to more professional networks, because sometimes this is traumatic enough for people that they really need that extra support on an ongoing basis that cannot really be provided adequately by a colleague on their unit or even a supervisor. So we pulled this quote from Albert Wu, who's at Dr. Wu at Johns Hopkins, who's studied this in depth. And he says that physicians and healthcare workers are just human, and we forget that sometimes. Strangely, there's no place for mistakes in modern medicine. Society has entrusted physicians with the burden of understanding and dealing with illness. Although it is often said that doctors are only human, technological wonders, the apparent precision of laboratory tests, and innovations that present tangible images of illness have in fact created an expectation of perfection. And I think this is very true today. We see it in the media after things go wrong in healthcare, and I see there are 165 people on right now, and I'm sure you've all seen this. There's this expectation, this somewhat unreasonable expectation that we know how to do everything, we should know how to do everything perfectly in healthcare. And on our side, that healthcare is messy. It's exceptionally complex. It's complex in that our patients are different and have different needs. It's complex in that we're relying on the skill set of millions of humans to provide consistent care and knowledge on an ongoing basis. It's complex because the technology doesn't always work as planned. It's complex because we have to provide this care 24 hours a day, 365 days a year. It doesn't stop, unlike other industries. And we need to keep that in mind as we care for our caregivers after some of these events. So what I'm going to show here is really just some images, and you can just go through them around how healthcare workers are struggling. A lot of these are around COVID, but this also goes in line with what we were seeing before about physician and nurse burnout, people leaving the healthcare profession. It's really a huge challenge for all of us because it's hard. COVID has only made this more apparent for us. And then if you put on top of that medical errors or things that can go wrong, and it's not taking care of people after that, it's often why people end up leaving the medical profession. So when I used to do this, there were we had an older slide with older numbers, but we got some new numbers from 2019 on suicide rates in physicians and nurses. And the numbers here, when Zoe was able to find these for me, they are what I would call alarming. If you look at female physicians are 130% more likely to commit suicide than the general population. It's just such an incredibly striking number. And then you go down, male physicians 40%, female nurses 58%, and male nurses 41%. And what this really does is show you the burden of working in healthcare and how it has affected our healthcare providers. Some of you may have heard of Kimberly Hyatt in the past. It's a terribly sad story of a nurse, Kimberly Hyatt, who worked at Seattle Children's Hospital. She was a nurse there for about 20 years, and she made a medical error where she accidentally overdosed a baby Kai, who you see here, with 10 times the dose too much calcium chloride. She supposedly went home and realized it when she got home and checked, but it was too late. Kimberly was disciplined, I believe, by the nursing board. I'm not sure if she lost her job, but I think she did. She was the mother of 2 younger children and had a partner, and she committed suicide 7 months after this event because we didn't take care of her after this event. She was a good person, a good nurse, engaged in the care of patients, and as a healthcare system overall, we didn't take care of her when she made an error that almost anyone else could have made. And so we need to protect our healthcare workers. By providing care for the caregiver, we can reduce burnout. We already talked about that. Reduce depression and suicide. Create a supportive work environment. Keep individuals in the healthcare profession longer and prevent turnover. These are, when we look at depression and suicide, of course, we absolutely want to prevent those. Some of these other benefits of protecting our healthcare workers through a Care for the Caregiver program are really beneficial to the healthcare system. So we're keeping individuals in the healthcare profession longer, so we maintain that knowledge base that is so important. Preventing turnover, as most of you probably know, turnover is exceptionally expensive and time-consuming for the rest of us who are in the system. And creative and supportive work environment, we're really continuing to try to do that to make healthcare a place where people want to go and care for our patients. Final component of the Candor program that I want to talk about is event review. So what you hear, I'm really doing this at a very high level. When we look at event review, it was designed differently for Candor than the typical RCA. And instead of bringing people, doing a little bit of background work and then waiting to bring people into a room to determine what were the contributing factors of an event, what are we going to do about it, we redesigned it. And why did we redesign it? Because a lot of times we heard that in order to perform one of these root cause analyses, we were waiting for physicians whose schedules were tight, we were waiting for nurses who were working overnight, and we would end up scheduling meetings weeks to months after the event actually occurred. As we talked about earlier, when one of these events happen, it's like a plane crash for our families, and we have to act like the NTSB and can learn and communicate as quickly as possible. So the Candor event review process really breaks it down a little bit differently and talks about an immediate response. So immediate response is caring for the patient and the family. So clinically, we want to do that. We also want to begin that initial communication with the patient and the family. Care for the caregiver program. So really important that we care for our caregivers, as we just talked about. And then this part is important too, gathering time-sensitive information. So what do we mean by that? So it's the telemetry strips that are on the monitor or on the floor that are going to be lost if we don't do this. It's going to the unit and collecting those medication bags that may have been involved in the event. And it's maybe even quickly interviewing people, looking at lighting, looking at how busy the unit is, what was going on at the time. Really, really important, because if you miss it in that moment, you can't get that time back. The next part is the in-depth review, and this is really getting into the meat of the review itself. And before we actually have a big meeting of anybody in the Candor event review process, we really want to put a lot of effort into figuring out what we think happened. This is really, really important, and I saw there are a lot of patient safety officers and people in similar roles on the call. This is what you do, and this is where most of the work is supposed to occur. So interviews, and when we do deeper dives on this in future webinars, we can talk about some of the process around interviews, but getting those interviews done early and really learning from the people who are involved in the event. Understanding the context. So some of this is doing really detailed chart review. Some of it's going to the unit and looking at equipment and looking at how it's designed. What happens is when you start doing these interviews, looking through the medical record, looking at the equipment, doing all this really deep dive work early on, as safety professionals, you will start to see what these causal factors are bubbling to the top. You understand this world, you've seen these things before, and they start to bubble to the top. This is very different from the classic root cause analysis when we put a whole bunch of people in the room, usually doctors, nurses, maybe pharmacists, maybe the people who clean the floors, the people who deliver the food. We put them all in a room and we ask them, who are not necessarily trained in safety, to come up with what the safety issues are. That's not what we do in the Candor event review process. We allow the safety professionals to look for these safety issues, and once these bubble to the top, this all gets presented at a meeting, which is called the confirmation and consensus meeting. So if it's a piece of if it's a piece of IT or IS equipment or a pump issue or a workflow issue, all that gets presented to the people in the room, and then those people get to say, yes, I agree with you. No, you didn't get that exactly right. And eventually the team comes to a consensus on what those contributing factors or causal factors were. We don't look for a root cause. We look for causal or contributing factors. And that's because what we found is there's rarely one root cause. There, especially in the complex system of healthcare, there are lots of different things that can be causing these events. Either in that confirmation or consensus meeting or later on, there's a solutions meeting, and then there's follow-up. This slide and the next slide, I think, from the event review perspective, I think are some of the most important. So we call this minding the gap, and if you click on this, it's animated, please, Shelley. And we want to really figure out the gap between work as imagined and work as performed. So work as imagined is what managers or people in administration, and I am and have been one of them, believe the work is being done, the policy, so this is what's supposed to happen. We'll talk about this in the next slide, how the work is actually being done. In your event review process, this is one of the most important things. It's being curious and asking over and over, show me what you do. Not judging, but just show me what you do. Because if you actually understand the true work, then you can design true solutions and maybe narrow the gap between that work as imagined as work as performed. If you don't ask, if you aren't curious enough, if you don't create enough trust and people don't show you what they're actually doing, your solutions will likely not be aligned with what would most likely fix the problem. And this is how we try to frame it. So it's what is supposed to happen, right? So that's the policy of the procedure, how is this normally supposed to happen. What usually happens, so if everyone in the room with me, I'd ask you to raise your hands and tell me if you have ever seen a workaround in healthcare. Nurses are the best at this probably because they need to be resilient. What usually happens, and it usually works, and what happened this time? What was different this time from what usually happens? With all that information, you can put the pieces together and design new solutions that actually will hopefully reduce the risk of similar events happening in the future. And this is called the system approach. So we're a human factors group, and we say, although we cannot change the human condition, we can change the conditions under which humans work. Yes, we want to train people. Yes, we want to make them better at what they're doing, but humans will continue to make mistakes, especially when they're working in complex environments such as the one you see on this slide. So effective and sustainable solutions. So we talk about once we get that information of work is imagined versus work is performed, and we think about what contributed to this event, how do we fix this best? And we can think about that in terms of short and long-term solutions, ease of cost of implementation, and employing a suite of recommendations. We want ones that are going to be effective and sustainable. So we're going to click through some images now. So train crossing, right? The problem here is that people can get hit in their cars when they're crossing the road, crossing the tracks. So one initial easy and inexpensive short-term solution is to put up a sign that just says railroad crossing. And that'll work some of the times, but humans are still going to be distracted. They're still going to go over the tracks when they shouldn't. So it's maybe a short-term solution, but not great. So here's the next step, right? This is a little more expensive, it's a little more disruptive, but putting down a gate is going to make it less likely that people are going to go over these tracks. So we know we've all heard stories about people going around the gates. People can still walk across the gates, walk across the tracks. People cannot be paying attention and crash through the gates. So this is a much better solution. It will reduce the risk of something like that happening again, but still not mistake-proofed. And here you see it's virtually impossible for a car to get on the tracks. It's harder for somebody to walk across the tracks. It's more expensive, but it's a longer-term and better solution. So this would be an effective and sustainable solution. It's probably rare that someone would get hit on these tracks. And now if we want to put this all together, so we talked earlier about the University of Michigan experience. This has been the experience at MedStar. I used to be in charge of the patient safety program for the organization. And if you look here, you can see that our overall liability expenses have gone down over the years. And I will tell you that this is despite the fact that we have expanded our footprint at MedStar. And this was while we were implementing Candor. So Candor really started doing this similar work before it actually came up from AHRQ, probably in 2012, 2013. And you can see what happened after that is that what we were putting away for risk dollars every year far exceeded what we were actually paying out. And that has continued to date. And we saved about $100 million over a 5-year period. And I think that's it for my presentation. And I'm going to turn it over to Michelle now to continue with the presentation.
Thanks, Seth, and thank you, Zoe, for your assist there and being on the ball. I'm going to talk a little bit about what we're planning here at the Authority with our collaborative. So now that you've all heard about what Candor is and some of the component pieces, I'm sure you're all super excited to sign up to implement this in your facilities. What we're going to do is basically help you with that. So Seth mentioned the component modules. He mentioned the main 4 there at the top, and then also organizational learning and sustainability we'll do as our 5th module. What we'll do with each of these is there will be about a 3-month time period for each of those modules. We'll have some collaborative-wide webinars. We'll have some opportunity to do facility or organizational focused education and consultation. One of the things that we know, from our work with facilities and conversations we've had with facilities is a lot of you have a lot of these pieces, but each facility has a slightly different setup currently. So, maybe you have a really robust Care for the Caregiver program, and when we focus on that module, you won't have as much work to do in that area. But maybe your disclosure is an area that will be a little more work. So it's hard for us to say exactly how much time and effort it's going to require for each facility because it is going to be very facility specific. So here's our anticipated timeline. We're obviously in February. February, we're introducing the topic. We're seeing who's interested. In March, I'll talk about next steps, but we'll have a facility gap analysis self-assessment to complete to get kind of a baseline for where each of you are, and a letter of intent, because one of the things, if you look at these components and you look at this work, this isn't something that one person can just start doing. It really is a change in the culture and the organizational thinking. So there's actually a letter of intent that will ask you to have your senior leader sign that identifies a project lead who will be our main point of contact, but acknowledges that you're going to embark on this journey with us. We'll spend the next few months doing the component modules, and then we'll wrap up in July of 2022 with this project, and we'll launch a second cohort. So if you really want to do this, but you just don't have the resources right now, we understand that. We're going to launch a second cohort in July of 2022 for facilities who can't do this first round, or if everybody who's on the phone today decides that they really want to do this. I don't know if we have the resources to support that many facilities all at once. We would probably see about trying to break up into those two cohorts. If we have enough interest, we can do additional cohorts. If there's only certain component modules you're interested in and you don't want to commit to the whole project, that's something that we would look at doing after this first cohort is done. So key points, we're not asking for any additional data submission. I know when you participate in a collaborative, that's usually one of the first things is what data am I going to have to collect for this? There will be facility self-assessments or checklists that you'll need to complete, but that's to know what your next steps are and figure out which things you already have in place. But we're not asking for any extra data collection beyond those. As Seth mentioned, there's benefits to patients, family, the whole healthcare team, the facility. It is an 18-month commitment. You do need that leadership support. You are going to have many disciplines involved. This isn't, again, something that one person is going to be able to do. You do have the expertise of the authority team, along with MedStar, who's going to be working with us to put together all of these webinars and the supports for you. But really, you're going to get to tailor the work to your specific facility needs. We know this isn't a plug and play. Like you'll have to assess where you currently are and what needs to be done, and then we'll help you figure out how to do that. So if after all of that, you're still ready to go, you can send me an email. So my email is michbell@pa.gov, and let me know that you're interested. If you have questions before you commit, certainly feel free to reach out. I'm happy to answer any questions. If you currently have questions, you can enter them either in the chat box or the Q&A on the right-hand side of your screen, like I mentioned earlier. But as you think about this, you may come up with other things that you want to ask, and certainly I'm available to answer any of those questions. Once you email me, we'll start figuring out who your project lead is going to be and who you want to involve within your team. I'll get you a copy of the letter of intent and the gap analysis, that first self-assessment to do, and those you'll return to me. The signed letter I need no later than March 26th with your commitment, and the self-assessment you'll have a paper copy, and then we'll have you enter those those answers online and submit them to us, and that will be by March 31st. So those will be the next 2 due dates. If you have any questions that come up, feel free again to reach out. So with that, we'll move on to Q&A. Again, if you have questions, the chat box and the Q&A on the right-hand side of your screen. If you don't see them, you can click on the bubbles on the bottom that say chat or Q&A and type them in. It looks like we do have a couple questions here. Seth, did anything change in the external legal or regulatory environment in advance of your Candor implementation?
So actually, no. Though we have since our legal team and our government affairs team have been working with the state of Maryland, the legislator, to actually, and Jack Gentry actually went to testify to actually change it. It did not. So Larry Smith, who's our vice president of risk for the entire MedStar system, has done this for years, believes in it, and is fully supportive of it. So nothing really changed externally. We just did it. And, you know, just to be transparent about everything, for the most part, it does work. It doesn't mean that there's never a payout for a case. We still, if, again, I said earlier, if we harm somebody, we owe them money and they need money, we do provide it to them. But we do that because it's the right thing to do. But there was nothing external that changed that enabled us to do this better. We just did it.
Okay. There's another question. Will the modules be available to the public online like this session, or will that be per facility? Right now, the modules that we do through the collaborative will just be available to the collaborative participants. You know, on the AHRQ site, there is certainly a lot of Candor resources, and a lot of the program documents are there. If there's like a particular area, you know, that you would like to do within your facility, like I said, we could look at some of those after the cohort 1 is completed. There's a question about getting a copy of the slides to share. And Shelley, I think you had posted a copy or a link to the slides as well. Someone else asked, should we let you know now if we want to join cohort 2? And certainly, if you know that you're certainly in on cohort 2, we can reserve your spot now. I would love to do that. So feel free to reach out if that is the case. Here's another question, and Seth, feel free to jump in on this one. Who do you recommend be on the team, and how many team members?
Yep. So it'll vary from site to site. So a lot of times it depends on resources. There's hopefully you have someone in your organization who has some training in safety. That's probably that person. And if that person is not clinical, to pair them with a good clinical person who can do a chart review. Those are really important things. The safety component is really important, and then the clinical component. But the other thing that's really important for this is mindset. So I talked a little bit about curiosity, and then I talked about the importance of interviews. So interviewing is a skill that requires empathy and curiosity, and it requires the ability to gain the trust of the people you're speaking with. That's really important. So for the event review part, you need somebody who's empathetic, who can ask the right questions, has some sort of patient safety background and clinical. For the Care for the Caregiver program, again, I'm going to say empathy again, meaning people are empathetic. And we just had people sign up. That's not hard. It's often not hard to get people to sign up to do Care for the Caregiver, because this really resonates with healthcare providers. Because for those of you who have provided care, I think every one of us has been involved in some sort of harm event or mistake where we felt terrible and were left alone. And when you start talking about care for the caregiver, there's usually someone in the room who starts to cry and talks about a previous story. So it's not hard to find people for care for the caregiver. Again, and it's not hard to pick the right people because the people who show up usually want to do it and are caring. For the disclosure part, the way we like to think about it, we train people around our system on this using, and we'll talk more about this in the disclosure webinars that we do. We train people on how to do it. I like to say as a palliative care physician and a safety person, for some reason they overlap. It's again, for disclosure, it's really about walking into a room, and the same thing with palliative care, checking my feelings at the door and really being focused on how do I do everything in my power to help the people and understand who they are and what they need. You know, you have to be smart about who does that. If you have certain, I'm a physician, so I can say this, certain physicians who are are very technically good at what they do, but maybe don't have the highest emotional intelligence quotient, you may not want to send them into a room with somebody alone. You may need to pair them with somebody who can listen better and guide them to where they need to be. So picking your team is really important. And that's maybe a longer conversation, but I hope that helped.
No, and I would say too, I think, you know, as we look at the makeup of facilities across the state, you know, the needs of each facility may be a little different. If you're at a small ambulatory facility, it may be almost all of your staff who are involved in some way or another. If, you know, you're at a large hospital, that is going to look different than it will at a critical access hospital. So, you know, there's lots of ways that it could be, and I don't know that there's a right answer. We just have to figure out what the right answer is for your specific facility. As far as, you know, the team for that initial self-assessment, it will be, you know, whoever you need to involve to get the correct answer. You know, don't make assumptions about what's happening in your facility. Ask the question. There was another question about due dates again for the letter and self-assessment. The letter of intent is due March 26th. I would encourage you, though, if you are interested, to, you know, obviously send me an email sooner rather than later, so I can get that stuff out to you. Another question, at what point do you involve the insurance carrier in the early resolution process?
So I can take that one.
Okay.
So it depends. For us, we are actually self-insured with a captive insurance company for most of our caregivers, but we do have other insurance carriers covering some of our physicians. So just like everything else, early is really important. There is sometimes a challenge when certain insurance carriers are not on board with this. So really working with them is important, and developing long-term relationships with them is really important. Because whereas we may say, listen, we're going to go in and talk to the patient and family, sometimes they don't encourage that. But talking to them early and also explaining to them why this is important and why this works is essential.
So great news. Thursday, we're going to do the same presentation again. So if your insurance carrier or your risk retention group, if you would like to get them engaged or on board, you know, have them listen to the presentation on Thursday, or have them listen to the recording. Because I agree with Seth, like, getting them on board with the process is going to make it easier later on in the collaborative. And then as you move forward with this, because again, this is going to change how you operate within your facility. Let's see here. We have another question. It says, as you know, in Pennsylvania, we are required to disclose to our patients. You know, in MCARE, there's that notification piece that's very important to the law. What would you say, Seth, has changed as a result of using Candor in Maryland?
So a few things. One, I mentioned earlier that there's now the legislator is hearing and considering bills to support this kind of work. That would be one. I think the other thing that's changed is probably our risk department's relationships with plaintiff's attorneys and actually with our defense attorneys. So that is huge in that there's much more collaboration, I think, in viewing this as we're all in this together to actually get the patients what they want and what they need, which is really important. That's on the plaintiff side. On the defense side, we actually did some simulation training on for them on how disclosure goes, and we had them do it to make them feel how uncomfortable it is. So that was really important. So they have a much better sense of what it takes to disclose and what's going on. They really say it gave them different perspective when they're defending us in cases. So there's overall, I think the big thing is that there's a lot more conversation about how this can be done in a better way that's probably saves everyone some money and also does the right thing for our patients and families.
Okay. I have another question. Someone missed most of the presentation because they got caught up in something else and wants to know how they can access the recording. So there's a copy of the slides available on a link that Shelley is posting in the chat box. There's also, we will post this recording, but we're going to repeat the same presentation on Thursday. So if you only caught the last half of this and you want to participate, certainly feel free to sign up for the Thursday webinar. And then we're almost out of time. I have one more question here, and I think this is a good one, Seth, for you to end on. What is your internal process for determining monetary compensation? Does the patient have an attorney involved?
So I'll respond to this based upon what I know. I've worked closely with our risk department for years, but I'm not actually in the risk department. So it's determined by them. It depends. So one, I will tell you what our VP of risk says over and over. We communicate with patients and families. If we think that there's going to be some sort of negotiation around money, he actually recommends that they get an attorney. He feels that protects them and enables them to help them communicate what they need. So that's, some people kind of gasp or they don't understand that. But he actually will say, I think it's important for you to be adequately represented in this process, really important. And then there are other things, we do what other people do. So if a patient is injured, we will have people help us create life plans. So how much is this really worth in a life plan? How much is it going to cost? And then there are standard monetary caps, but there's a whole process that they go through that should be done mostly in risk departments. But I hope that gave a little more context to it as far as getting, when you say, did the patient have an attorney involved? We often would want them to have an attorney involved if we're negotiating. It protects them. And again, we're focused on what's important to the patient and the family, especially if we harm them.
Okay. Well, we are a couple minutes over on time. Again, if you have any questions or would like to let me know that you intend to join either cohort 1 or cohort 2, please email me, again, michbell@pa.gov, and I look forward to hearing from you. At this time, this concludes our webinar. Thank you again to everyone who joined us.